If you or someone you love has peritoneal mesothelioma or mesothelioma that's spread to the abdomen, you're probably already familiar with one of the most distressing and difficult to manage symptoms of this disease, the buildup of fluid in the abdominal cavity that's called ascites. The abdomen swells, becomes uncomfortable, and then painful. Breathing becomes difficult as the fluid pushes up against the diaphragm. Eating becomes harder as the stomach has less room to expand. And in many cases, the fluid comes back, sometimes within days of being drained. Today, I want to talk about what malignant ascites actually is, why mesothelioma causes it, and most importantly, what the full range of management options looks like. Because drainage alone, while sometimes necessary, is not the only answer, and there are approaches that can provide more sustained relief and better quality of life. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a doctor, and this is not medical advice, but today I want to give you a comprehensive picture of how malignant ascites is managed in mesothelioma. One that goes beyond the basic answer of drain it and wait for it to come back. Let's start with why malignant ascites develops in the first place. In peritoneal mesothelioma, tumors growing along the lining of the abdomen disrupt the normal balance between fluid production and fluid absorption in the peritoneal cavity. Tumors increase the permeability of blood vessels in the peritoneum, and that makes them leaky. At the same time, it impairs the channels responsible for draining that fluid away. The result is an accumulation of fluid in the abdominal cavity. Some of that fluid comes directly from leaky tumor vessels, and some's produced by the tumors themselves. The volume can become extraordinary. Patients with significant ascites can accumulate several liters of fluid in the abdomen, producing visible distension, a sensation of fullness and pressure that never goes away, difficulty bending, difficulty breathing deeply, and eventually significant pain. Malignant ascites from peritoneal cancer carries a serious prognosis. Researchers have estimated that the median survival for malignant ascites is approximately 5.7 months, with survival from refractory ascites, which means ascites that doesn't respond adequately to initial management, of only 1 to 5 months. These are depressing numbers, and they underscore why the management of ascites in mesothelioma is fundamentally a quality of life issue as much as a medical one. The goal isn't just to remove the fluid, but to give patients as much comfort and freedom from its stress as possible for as long as possible. The most immediate intervention is paracentesis. It's a procedure in which doctors use ultrasound to guide a needle or small catheter through the abdominal wall to drain the fluid. It provides rapid relief, with most patients feeling significantly better within hours of a successful drainage. Pressure goes away, breathing becomes easier, and the abdomen feels less tight. For patients with an isolated episode of ascites or a first occurrence, paracentesis is the right first step. It can often be done as an outpatient, it's generally safe in experienced hands, and it provides quick relief. The problem is that for many mesothelioma patients, the fluid comes back, sometimes within days. Requiring repeat paracentesis every week or two is burdensome in ways that extend beyond the procedure itself. It means repeated trips to a clinic or hospital. It means repeated needle insertions, and quality of life is constantly cycling between relief immediately after drainage and progressive discomfort as the fluid reaccumulates. This is the point at which management needs to go beyond drainage alone. Now, before I go on, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. Now, one of the most meaningful advances in the management of recurrent malignant ascites is something called a tunneled indwelling peritoneal catheter. It's a semi-permanent drainage system that's placed under the skin of the abdomen. The insertion procedure is brief and typically done under local anesthesia. Once in place, the tunneled catheter allows the patient or a caregiver or home nurse to drain accumulated fluid at home on a schedule tailored to how quickly the fluid accumulates without needing to make repeated clinic visits for each drainage. The most commonly used system in the United States right now is the Pleurex catheter, which is the same brand used for managing pleural effusions around the lung. Research on tunneled peritoneal catheters in malignant ascites has found that these systems effectively reduce ascites-associated symptoms and significantly reduce hospitalization rates compared to serial paracentesis. A prospective trial found a 100% technical success rate for the catheter placement, and patients reported meaningful reductions in abdominal discomfort, reduced need for hospital-based procedures, and an improved ability to remain at home. For patients with refractory ascites who are well enough to manage catheter care at home or who have caregiver support to do so, a tunneled catheter is often worth discussing with your care team as a way of shifting from reactive crisis management to proactive, comfortable symptom control. Researchers found that a non-tunneled semi-permanent bedside peritoneal drain, which is an alternative approach that's even less invasive, provided symptom relief in over 92% of patients, allowing 60% to return to home-based care without requiring additional hospital visits for paracentesis. Diuretics are medications that promote fluid excretion through the kidneys, and they're sometimes used to manage malignant ascites, but their role is more limited and nuanced here than many patients would expect. The diuretics used for malignant ascites work best when the ascites is driven by mechanisms similar to those in liver cirrhosis, especially sodium retention and elevated renin activity. When cancer-related ascites has this component, patients may see a benefit from their use. But for ascites primarily driven by tumor-related vascular leakage and lymphatic obstruction, which is more common in peritoneal mesothelioma, diuretics are less likely to be helpful, and they do carry risks of dehydration and electrolyte imbalance. The use of diuretics for malignant ascites varies among physicians, and there are no large randomized controlled trials establishing their effectiveness in this setting. The decision should be individualized with your care team. Addressing the underlying disease through systemic therapy, chemotherapy, immunotherapy, or both, is arguably the most powerful answer available for reducing malignant ascites in mesothelioma. When treatment reduces the tumor burden, the mechanisms driving fluid production and accumulation are also reduced. For patients whose peritoneal mesothelioma responds to cytoreductive surgery and HIPEC, which is the heated intraperitoneal chemotherapy we've discussed in earlier videos, the surgical elimination of visible disease can dramatically reduce or eliminate ascites. For patients receiving systemic chemotherapy or immunotherapy, a treatment response can slow the rate of ascites reaccumulation, even when the fluid can't be eliminated entirely. Research into drugs that block tumor blood vessel formation as a specific therapy for malignant ascites is ongoing, with 2 prospective phase 2 trials going on that found it prolonged an interval between paracentesis, though the overall benefit in terms of survival was modest. This remains an area of active investigation rather than established standard practice. Nutritional support is an important but often overlooked component of managing ascites. The fluid buildup of ascites is protein-rich, meaning each time fluid is drained, a significant amount of protein is removed from the body, and this can accelerate malnutrition and muscle wasting. And that, in turn, worsens overall function and tolerance of cancer treatment. Collaboration with a dietitian who understands the nutritional needs of cancer patients with ascites can make a real difference in maintaining the patient's strength and quality of life. To review, malignant ascites in mesothelioma is driven by a tumor-related disruption of fluid balance in the abdomen. Paracentesis provides immediate relief, but it's often not a long-term solution for recurrent ascites. Alternative treatments include the placement of tunneled, indwelling peritoneal catheters that allow home-based drainage. These significantly reduce the burden of repeat clinic procedures and diuretics, which have a role in select patients. Systemic therapy aimed at controlling the underlying disease is the most powerful long-term approach to reducing ascites. Whatever the solution, nutritional support throughout is essential. You can visit mesothelioma.net for more information and resources on peritoneal mesothelioma and management of its symptoms, or call us at 1-800-692-8608 or use the live chat feature on our website to speak with someone right away. As for me, remember to post your questions below, and I'll see you next time.